Southern California and the state's Central Valley are reeling. Less than 2% of ICU beds there are available. It's one of many records that are being set all over the country.
The mountain states are getting hit hard now, including Montana, where many hospitals are overwhelmed with COVID-19 patients.
In India. Today, the country confirmed nearly 350,000 new coronavirus cases. And with so many COVID-19 patients, India's health system is collapsing.
It's become an all-too-common story throughout the pandemic. Even with social distancing and lockdowns, many medical systems still face huge surges of patients. Some have managed, but some have become overwhelmed. And even in communities that have been spared the worst, those hospitals still need to be prepared. How should they do that? How do they know what works and what doesn't? And what can we learn from their experiences now to be better prepared for the next wave of cases, or natural disasters, or even the next pandemic? I'm Owen Perry, and today we'll be talking about research here at Oregon State that's working to document what hospitals are doing to manage and adjust to surges in real time, and what impact those changes are having on patients. From the College of Engineering at Oregon State University, this is Engineering Out Loud. In hospitals, countless decisions are being made every day. Which rooms need to be isolated? How much PPE needs to be ordered? Who goes to the ICU and who has to wait? When we look back at the pandemic, we can view each decision as a single point of data. And if you gather that data, you might just start to see patterns. What's working? What isn't? What can we learn that will help us better respond the next time? Joe Agor, an assistant professor of industrial engineering, has been doing just that, collecting a record of the decisions that have been made in 2 hospital systems during the pandemic.
My area of expertise is in optimization methods and data mining. More specifically, I have done work in using bi-level optimization for feature selection.
In other words, he sifts through large amounts of data about systems that are embedded in larger systems, like hospitals, and tries to figure out how to use that data to make improvements. Specifically, he analyzes large-scale electronic health records to identify patterns in patient health outcomes. For most of the last year, he's been working to document the decision-making processes of hospital systems before, during, and after the pandemic. The goal is to provide tools to help hospitals better manage medical surge capacity for future pandemics or natural disasters.
So this work was funded through a program called NSF Rapids Program, through the National Science Foundation, NSF, which that program's main goal is gathering information that may otherwise be lost. So in emergency situations or disaster situations, or when things happen quickly, information wants to be gathered so that we don't lose what we either learned from it or what we did.
So for this project, they wanted to gather information related to how hospitals prepared for, reacted to, and managed surges of patients during the pandemic. Joe hopes to gain insights into what those real-time adjustments that the hospitals made had on both the patients with COVID and those without. He and researchers at North Carolina State University have partnered with 2 hospital systems, MedStar Health System in the Washington, D.C. metro region, and Samaritan Health Services here in Corvallis.
Wanted to get together a way to start documenting these procedures that were inevitably going to be put into place to manage this surge, right? To manage the surge to the hospitals. And so that we could look back on it, not like we're doing right now, to see, okay, what worked, what didn't work.
With access to real-time information as well as historical pre-pandemic health records from the hospitals, the group was able to document changes in things like intensive care units and hospital bed capacity, staffing, equipment availability, including personal protective equipment, and testing kits. Every decision to change a policy, reassign a doctor, or purchase more N95s was captured.
In essence, it's still very important to get an accurate documentation of what actually happened and how we responded, and boots on the ground, what we were doing day by day. Things like that are very difficult to recollect in hindsight without an accuracy of data, without accurate modeling. And I think that's what Joe's study is really going to provide us.
That's Dr. Bharat Gopal, a physician at Samaritan Health Services, who's been working closely with Joe and his team on this project. He talked to the researchers about what it's like from a clinician's perspective and what information is most important to capture.
My role in this is primarily to look at the fields that are being collected in the data set and determine whether this is something that we should consider to include or not include. Is this extraneous data, or is this going to be something that we want to use or that will be utilized? To me, data is only important so much as it's being used.
In the current pandemic, doctors have been having to respond without any historical data to support their decisions.
Imagine in 1918, we had an accurate depiction, data-wise, of what had happened during that pandemic. I think we will have a chronicle that we can use to accurately model or try to think through the layers of policy and practice that we used in making decisions and what exactly happened every time we did that. We make decision A, and then we have consequence X. We make decision B, and we have consequence Y. And every time we did that, we ended up with something else happening, Z, or something else happening that really was difficult to anticipate in the time. But now that we have this great data set, we can start to anticipate a little bit better if we have another pandemic, which I would say is not if, when we have another pandemic, a better understanding of how we can respond.
As you can imagine, there's a lot of data to work with. Ultimately, the team categorized it into 8 buckets. I'll let Joe rattle those off.
Category 1, policies around staff responsibilities, shift and work incentives. That's the one I mentioned. Category 2, staff scheduling changes to manage demand, so scheduling of staff. Category 3, patient care policy changes. 4 is COVID hospital testing policies. 5, interaction with external organizations. This could be government organizations or private organizations, nonprofits, those types of policies revolving around those. Internal organization and system management. 7 was non-human resources, resource allocation and management. Non-human resource being vehicle transportation units, PPE, ventilators. Those are non-human resources. And then the 8th category was policies involving exposure mitigation.
Like I said before, it's a lot of data. And even within those categories, there are these subcategories. Just think about staffing, for example. You have doctors and nurses, yes, but there's policies and actions for kitchen personnel, for janitors, for the people who change over the rooms. There's a lot of people that work in a hospital.
We went through each of those, picked out certain actions, certain dates, and things that really had dates so that we could understand when those policies or when those actions were taken by the hospital system.
Once the team identified a list of these policy changes and when they went into effect, they could compare those to the hospital records and see what patterns emerged in regard to how well patients did. So now that they have all this data, what did they find out? Well, that's kind of a tricky question to answer.
When we're trying to establish what was successful, what was working with managing medical surge, it's not just counting policies and seeing what actions took place and making a correlation, because there are different variables like compliance or like movement of people and many others that can inform causation. It can inform different outcomes. So we're trying to capture now an excess amount of information and present that information alongside it.
Still, there are tangible patterns that stand out. One example was the use of telehealth, where doctors meet with patients virtually.
Something that we can say is that the telehealth initiative that was instituted here at SHS was very successful in managing the surge of patients to the hospital system. That is something we see in the demand patterns to each of the different 5 hospitals within Samaritan Health Services. Telehealth was a thing for Samaritan Health Services before, but in 2019, there were maybe 1 or 2 throughout the year that was a telehealth. Whereas in April of 2020, when we started transitioning, when they made that major transition, more than 50% of their patients moved to telehealth. Physicians needed to be trained. And again, this was in an effort to manage the amount of patients that were flowing and out from the hospital, which again, that part was successful.
There's another part of the health system that we haven't really touched on yet, and that's the patients. And I'm not just talking about the patients who were sick with COVID. What about the ones who should be seeing their doctors for another reason, but aren't?
The thing that I think we want to get the message across, is that surge is not just related to the pandemic at hand. Whenever the influenza pandemic happened, they were not just only worried about the surge of influenza patients. We're not just only worried about the surge of COVID patients. And this is something that our physician we're working with here at Samaritan Health Services keeps stressing, is that there are still very deadly chronic conditions that were pre-pandemic that, you know, we need to make sure that we keep an eye on. We understand that we have to manage COVID, absolutely, because that's killing people. But we have to make sure that we don't forget about the current chronic conditions, and that surge of non-COVID is, I think, the thing that we want to present information on.
Again, here's Bharat Gopal, the doctor from earlier.
When it comes to COVID, people have been scared and they've avoided coming into healthcare institutions when they've been ill. The question is how much and for how long, and what has happened to the severity of their chronic conditions or their acute conditions if they've avoided the healthcare system. If a patient comes in having waited 3 days or 4 days with chest pain because they didn't want to come into the hospital, and their heart attack has now progressed to heart failure, that can be a significant detriment to them and also their recovery, but also have a significant impact on the healthcare system too. And I think that what Joe's study is really about is looking at what has happened not only to the patient, but also to the healthcare system.
The next phase of this project will go deeper into looking at how non-COVID patients have fared. What happens to their hospital stays? Were they significantly longer because they were putting things off? Did they have to go to the ICU more? Was there a higher mortality rate?
Maybe that'll lead to people saying, well, let's investigate that a little bit further, right? And let's dive and spend some money in identifying causation of these particular patient populations that are not COVID, but that somehow reflected in the data had some negative outcome, negative impacts, if that actually is the result that comes out.
That's the thing about this kind of research, especially as the pandemic continues and our responses to the virus shift and adapt. There's always more data to look at, more decisions to document, more causations to discover.
Our group is having ongoing discussions about different ways that we can use this data we collected to push to go in a different direction as we move forward. And it's going to be a function of what is needed as we move forward in this COVID pandemic. Is there another surge coming up? Now vaccination is the main focus, right? And so that's I think my last tidbit is I'm hoping that we can take this and continue to use it in some force of good.
So that's a wrap on what we all hope is the one and only season of Engineering Out Loud about COVID-19. This episode was hosted by me, Owen Perry. Will Havner mixed and edited the sound. A special thank you to everyone on the Engineering Out Loud team who has worked to put these episodes out despite all the challenges of the past year. Those folks include executive producer Rachel Robertson, hosts Steve Franzel, Keith Hautala, and Chris Palmer. Johanna Carson takes care of all things visual and digital for us. We'll be back really soon with new episodes, so stay tuned. Our intro music is The Ether Bunny by Eyes Closed Audio. You can find it on SoundCloud. We used it with permission of a Creative Commons Attribution license. The music and effects in this episode were also used with appropriate licenses. For more episodes, visit engineeringoutloud.oregonstate.edu and subscribe by searching Engineering Out Loud on your favorite podcast app.